In this video, we'll talk about injuries that can happen early on in life, either during the birthing process, immediately before, immediately after. We're going to go through 4 different diagnoses here in this lecture. So we'll start off with a very simple brachial plexus birth palsy. That's exactly what it sounds like. So palsy is some kind of weakness or damage that happens to the brachial plexus during birth. Cerebral palsy follows that. So again, palsy, so some kind of damage, weakness, we'll say, in the cerebrum. So this is if we have damage to the cerebral cortex or white matter. And that's the big wrinkly part of the brain where we do all of our thinking, stuff like that. So we're having injury either to the brachial plexus or the cerebrum. That distinguishes those two. Then we have the 2 disorders, the muscular dystrophies and spinal muscular atrophy. Muscular dystrophies affect the muscles. Spinal muscular atrophy affects the lower motor neurons. And in both cases, we're going to see weakness and difficulty moving. Alrighty. So a brachial plexus birth palsy is pretty darn straightforward. In this case, it's a mechanical injury that's usually caused during a difficult birth. So if we're pulling on the arm or something a bit too much, stretching the neck, that can cause physical damage to the brachial plexus. Here you can see we're certainly under 1% in terms of the incidence there, so 50 to 200 per 100,000. And the risk factors here make quite a bit of sense, right? So a large baby, that's that macrosomia. So we've got ourselves a big baby that's going to have a more difficult time getting out. So there's a potential to have to pull on the head there, stretching the brachial plexus. If there's difficulties during the birth, even with a baby without macrosomia, if the shoulder, for example, if the baby gets turned and the shoulder then gets stuck there against the pubic bone, well, that's going to be problems there when we go to pull baby out here. That's going to push shoulder downward, stretching the brachial plexus. And of course, we can have difficult births because, well, we have more than one kid in there. That can make it difficult to get them out. And then maternal diabetes and obesity also cause difficulties with birth. Now, there's a few different types of brachial plexus birth palsies, and it depends on which roots we're affecting. So the most common there would be Erb's brachial plexus birth palsy, and that affects C5, C6, so we see weakness in the shoulder and upper arm. Klumpke is with the C8, T1, so lower brachial plexus there, thus affecting the wrist and hand. And then we can also have whole arm, where we affect the whole brachial plexus, and so that'll include both shoulder, upper arm, as well as wrist and hand. The characteristic features because of the damage. So here we're showing the roots that are affected in Erb's palsy, Klumpke's palsy, and the accompanying signs there. So we have the shoulder and upper arm affected there, giving what we call the wader tip deformity. So the shoulder kind of rotates forward, and then the hand kind of rotates so that it's held up. This is called a wader tip deformity because this is a way for, in the old days, a waiter to ask for a tip discreetly, so you could slide some cash in there without them looking. Totally different. Rather than pronating here, we're going to see supination. I'm pretty sure that's the right word. I think the palm is now superior. I might have screwed that up, so definitely check with Hannah. But here, now we're not affecting the shoulder and upper limb quite as much with the lower cord injury. Instead, we're affecting the hand and wrist, so now we get this claw-like hand. Pathophysiology is very straightforward. When we stretch the nerves within the brachial plexus, we tear axons, and that's the problem. So here's our brachial plexus here, simplified a bit for you. When we're pulling, a couple things can happen. We can stretch too much, so the nerve stays intact, but the axons are broken. We can actually rupture the nerve away from our roots here so we can rupture it somewhere in the brachial plexus. That's, of course, going to tear axons. This is more severe because the connective tissue has been damaged, so axon regrowth doesn't have a road to follow. So this is far worse, the rupture. And then we have avulsion, which is where we have rupture, but in this case it's at the roots, over here at the rootlets. They're breaking off of the spinal cord. Clearly we have a lot more problems down here with this avulsion, so we're going from least to worst there. Now, kind of a two-hit model here. So nerve stretching tears the axon, but then denervation of the muscle slows down motor development. So we're not going to hit our milestones at quite the same time. So brachial plexus birth palsies affect us in the present by tearing axons, but also in the future by affecting motor development. Cerebral palsy, here we again have some kind of damage, but now we're up in the cerebrum. So this is some kind of problem that occurs during that first year of life. So it could be in the womb, could be after. Well, early on, we have damage to the cerebrum. So here you can see still not a percent, so 200 to 250 per 100,000 births. And the prevalence is pretty similar to the incidence. So each year, we see about 200 to 250 per 100,000 births. And across all age groups, we have about 200 per 100K. So the survivability is pretty good, is what that means when the incidence matches the prevalence pretty well. Okay, so some potential risk factors here really come down to low birth weight and premature births. Those are big risk factors, and that explains the difference that we see between cerebral palsy rates in black infants versus white infants. And we can see it shown down here in this table. So here we're just looking at survival, showing us that the earlier the birth, the greater the risk in cerebral palsy. So if we have early births, preterm births, then we're going to increase the risk of cerebral palsy. And what we find is that those very early preterm births are a lot more likely, so about twice as common for the under 28 weeks, right? That's this group with the highest risk of cerebral palsy. There's about twice as many of those in the black pregnancies included in this study than white. Similar, but still elevated for the less than 37 weeks. So preterm, less than 37 weeks. Very preterm, less than 28 weeks. Now, what we'll notice up here is that as we get more advanced in gestational age, the risk of cerebral palsy, that's the blue line, increases. However, just like with Down syndrome, the percentage of all cerebral palsy cases is bigger for those term births. So you can make it to term and still get cerebral palsy. Yes, your risk is small, but there's a lot more of these births, and that's why they account for the lion's share of cerebral palsy cases. Not saying that preterm birth isn't a risk factor. I'm just saying that there are far fewer of those births, and therefore they don't contribute to the bulk of folks with cerebral palsy. So just because someone has cerebral palsy, we shouldn't think that they must have been a preterm birth. That's backwards logic. If they're a preterm birth, then they're more likely to have cerebral palsy. But the reverse isn't true. Okay, so all of these risk factors here, whether it's prenatal, perinatal, postnatal, you'll notice that they all have in common feeding the growing brain there. So if we have anything that interferes with, like placental attachment, blood flow, placental detachment, that's a problem. Problems with blood flow. Anything that's going to impair feeding the developing brain, that's a risk factor. Anything that has a risk of stimulating inflammation in the developing brain, that's a risk factor, right? So those maternal infections, the rhesus factor incompatibility, infection after birth, that's another problem. Traumatic injury, absolutely a problem. Or any early strokes, clearly going to increase the risk of cerebral palsy. Now, the low birth weight and the premature births increase the risk of that cerebrovascular accident after birth. So that's why they are risk factors. Okay, so what's going on in cerebral palsy is, in many cases, it's essentially ischemia, either because of problems with placental attachment or blood flow in the cord. We get insufficient blood flow, and that's particularly a problem in these border zones here. So those, or they're also called watershed zones. So the border between the anterior and middle cerebral artery, for example, or the middle and posterior cerebral arteries, these are border zones, watershed zones. And these are the areas that are most likely to experience ischemia because at each branch point, our arteries get smaller. So let's follow the MCA here, the blue line. As it branches, notice the radius of the blood vessel continues to creep down. In other words, our blood vessels taper. They come to a point, and that point is in the border zone. Now, if you think about this, because they have a smaller diameter, any little bit of stuff floating around is more likely to plug up that blood vessel in the border zones. So here's where we're going to tend to see drops in blood flow because it's easier to block. These are also areas that have a little bit less blood flow just simply by the nature of having a smaller diameter. Right? If we have a small diameter, that increases the resistance, which impedes blood flow. Now, if we experience hypoxia or ischemia, that's going to cause excitotoxicity. And this shouldn't be a surprise here, right? We got to pay the bill. So if we don't have blood flow, we don't have glucose, we don't have oxygen, so we can't pay the bill. We can't pay the pumps. Without pumps, we don't maintain that negative membrane potential, and therefore we depolarize, giving us excitotoxicity. Now, those premature births are especially prone to damage for a couple of reasons. First of all, myelination doesn't begin until pretty darned late in the pregnancy. And myelination of the cortex really isn't that noticeable until quite later on in development. In fact, myelination won't finish completely until we get into our fourth decade or fifth decade of life. So myelination happens after neurons create their connections. Of course, you have to have an axon before you can myelinate it. And so these preterm infants have neurons that aren't myelinated yet. The problem with this is that it means we have to spend more ATP on all of our action potentials. So we're a lot more dependent on changes in ATP because we have unmyelinated axons. So this point over here on the left, since we see very poor myelination in young brains, particularly in preterm infants, these neurons are very much dependent on constant blood flow. Here's the other problem. That's CNS perfusion, that is blood that enters this central nervous system, depends very much on arterial pressure in preterm births. The central nervous system hasn't learned to auto-regulate its blood pressure yet. So the cerebral perfusion pressure, so that's how much is going to get into the brain. This is the difference between the mean arterial pressure and the intracranial pressure. So if I have let's just say higher blood pressure, then that'll increase the amount of blood that goes into the brain. Okay, here we're looking at the stability of blood pressure in a full-term infant and then a preterm infant over here on the right. Notice fairly straight line over here on the left. Yes, they're on different time scales, but straight line. A clear downward creep over here. So here we're looking 60 minutes after birth. We've got a drop in blood pressure. So we're looking at about a little over 10 millimeters of mercury drop in blood pressure. Okay, so if we drop our blood pressure, Now that'll drop the amount of blood that goes into the brain. And so those really fine terminal branches, especially, are going to get a reduction in blood flow. And so not surprisingly, we see white matter lesions. Lesions in those border zones, like right here, right, with the fine terminal arteries. So here's a couple of white matter lesions on both sides of the brain. So these are going to affect the upper motor neurons that innervate our upper and lower limbs. And so in this case, we're seeing more severe white matter lesions and more severe symptoms. We have quadriplegia in this case. All right, so the ischemia is creating the white matter lesion. We have damage. What happens there? Well, those white matter lesions lead to inflammation, reactive gliosis. Okay, same story as last time. If we have reactive gliosis, we decrease glutamate uptake. E stands for glutamate, leading to dipole. So neurons depolarize, and then we get excitotoxicity. So that's an option. Because this happens so early, one other possibility is that the oligodendrocyte precursors don't properly mature, and so we don't form as much white matter, and this leads neurons susceptible to further injury because they remain expensive. More profound white matter lesions are called periventricular leukomalacia, and this is just saying that we have these diffuse, about 2 to 3 millimeter lesions, or 5 millimeter lesions. So noticeable lesions that are scattered around, and they tend to be around the ventricles. Hey, kind of like this. These are pretty common in cerebral palsy, especially in preterm births, because again, those are the brains that are most susceptible to these white matter lesions. So about twice as often as full-term infants with cerebral palsy. Okay, so we've got ischemia, and then we've got the white matter lesions that then causes reactive gliosis, the inflammation, that whole thing. Hey, infectious agents can also cause a problem here. So what about that maternal infection or infection, right after birth? Okay, so infectious agents or unconjugated bilirubin. So here's that neonatal jaundice. In this case, we're talking about severe neonatal jaundice. So newborns have physiological jaundice. Every newborn is going to have some degree of jaundice where there's a bit yellowing of skin because they just have an excess of blood. So as they kill off the excess blood cells, you'll see a little bit of jaundice. Totally fine. Severe neonatal jaundice is not, because high levels of bilirubin stimulate inflammation just like infection. Okay, what's the problem with inflammation? Twofold. If we increase intracranial pressure, what does that do? Well, that can decrease blood flow, and hey, we're right back where we started. Ischemia. Okay, what about reactive gliosis? Hey, same thing we just saw before. Decreased glutamate uptake. Both of these contribute to excitotoxicity. I'll just write excitotox. All right. That unconjugated bilirubin can do other things. Besides screw up astrocytes, they can also directly stimulate calcium currents in neurons. And that's what these data are showing us here. So what they're doing here is just a little voltage step. So we're holding the neuron at hyperpolarizing potentials, then we jump it up to minus 10 millivolts, and then we're back down to minus 80. And when we do that, we're going to activate voltage-gated ion channels. And what they've done here is isolate calcium channels. So we're looking at the calcium current here. That inward current is just showing us that calcium is coming in. That's it. So when calcium flows in, it creates a current, and that's what we're measuring. Okay, so the further this goes down, the more calcium is coming in. All right, so now let's do the same experiment, and this time we'll give them some bilirubin. All right, so here's black is control. Notice we drop down much further with the bilirubin, showing us that bilirubin increases calcium currents. What's the problem with that? Well, twofold. First of all, we can release excess glutamate. That causes excitotoxicity, or it could, right? So we could increase glutamate toxicity. The other issue is if we bring too much calcium into neurons or any cell, the mitochondria can be permeabilized, leading to apoptosis. So a couple of possibilities for bilirubin. Good old-fashioned inflammation or activation of calcium channels. Outside of our central nervous system, there are other problems in cerebral palsy. Muscle contractures are fairly common, and this likely has to do with a couple of changes to the muscle. First of all, we see fewer stem cells. They're called satellite cells, and as a result, we get much smaller muscle fibers developing. Here's the normal cartoon. Here's the cerebral palsy cartoon. Notice the cross-section, we have much smaller muscle fibers. And that's because they had fewer stem cells to merge together to make the big old syncytial cell that is muscle cells. Okay, the other problem, not only in a cross-section but in length, is that the sarcomeres are far fewer in cerebral palsy. As a result, they have to get stretched. So we decrease the number of sarcomeres, and as a result, we have to increase the length because that muscle still has a certain distance it has to span. It just has fewer sarcomeres to do it with, so each one has to be longer. This creates two problems. We don't have good overlap on the sarcomeres, which weakens the muscle. We also have a much shorter muscle, which increases passive tension at those joints, which gives them reduced range of motion. Can also lead to pigeon toeing, right? If the calves, there we go. I think that's the correct term for this muscle. If these are shorter, that's going to pull the, I believe it's called foot upward, right? So we're going to point our toes downward as a result. Okay, the other problem, besides not having big, long muscle cells, we have more extracellular matrix. And for that, just think collagen. That's a big part of it. Collagen is tough. So this makes the muscle tough. And collagen is not contractile. So we have tough, stiff muscles as a result. Okay, so here we're looking in cross-section on the left. So there's a cross-section of muscle. Notice the smaller fibers in cerebral palsy compared to control. And then the red is showing you collagen. A lot more red down here than up here. So we have smaller muscle fibers and a whole lot more collagen. So the muscle is not as strong, it's not as elastic, and it's more stiff. All right, let's see if we can summarize this a little bit. So I tried to put some important risk factors over here on the left, the pathophysiology that might occur on the right, and the outcomes that then lead to, maybe even more pathophysiology. So those placental disorders, obviously that, as well as the low birth rate, premature births, those contribute to hypoxia and ischemia. That's a problem because it depolarizes neurons. Those depolarized neurons then get the excess calcium that can lead to their death. Okay, that's an issue. Hey, neuron loss, by the way, can trigger reactive gliosis. What else does? Inflammation. Notice these arrows go both ways. Reactive glia trigger inflammation, and inflammation triggers reactive gliosis. This is nice. It makes a positive feedback loop, so anytime we have damage, we're insured to have reactive gliosis. But it can lead to problems. The other thing that causes inflammation would be that pre- and perinatal infection. Why are those risk factors? Because they cause inflammation. Inflammation can cause reactive gliosis, which, because of improper glutamate uptake, causes neurons to depolarize. Or that inflammation can increase intracranial pressure, causing insufficient blood supply, which leads to depolarization, or putting pressure on neurons that causes depolarization. And then we get excessive calcium currents and neurons die. Okay, one that I couldn't quite fit in very well just because of its direct arrow to excess calcium currents is bilirubin. So this would be severe neonatal jaundice. So that's more of a risk factor. Let's say severe neonatal jaundice is over here. So we get a bunch of bilirubin that can cause reactive gliosis. Again, depolarizing neurons, excess calcium, neuron loss. Bilirubin can also directly activate calcium channels. Okay, so there's cerebral palsy in a nutshell. You should then be able to answer these questions, I hope. If you can't, drop a line in the questions box, drop by the office, we'll chat together. Alrighty, moving on. Muscular dystrophies are progressive neuromuscular disorders that usually start in childhood, and these cause muscle wasting. So the problem is in the muscle. But since moving around muscles is, I'd say, the most important job of the nervous system, I think it applies to MedPath too. So we got a few different types of muscular dystrophy. Here you can see their incidence over here, how many per 100,000. So some are a lot more common than others. So Duchenne muscular dystrophy, most common type, at least in males because it's X-linked. Age of onset shown over here. Some come on pretty early in life, some a little later. And hey, those that come on early in life tend to progress rapidly, and those that come on later progress slowly. Rapid progression just means that the symptoms get worse and worse and worse. So we see more muscle degeneration, more weakness, worse outcomes. The muscle groups affected are over here. Sometimes it's built right into the name, limb girdle muscular dystrophy, right? So the upper arm and pelvic girdle muscles. But anywho, you can read that. You know more about muscles than I do. So this is just to say that these are somewhat rare, especially for some of the muscular dystrophies. So under 1% of the population for sure are going to experience this. In most cases, 1% of 1%. All right, what's going on here? So I'm trying to simplify muscular dystrophies as best I can because there's a lot of different genes that are mutated in muscular dystrophies. And I think we can summarize these into two broad classes of pathophysiology, the way I see it. The first class would be dysfunctional dystrophin complexes. Okay, let's start with the dystrophin complex. I believe I've made dystrophin green here. Oh, look at that, I did. So dystrophin is a protein that links up to surface proteins that hold on to the extracellular matrix. That is, of course, collagen. You remember that. We just saw it in a slide. So collagen's nice and tough, and this will help stabilize the muscle to make sure it doesn't get stretched or compressed too much, causing it to pop. That is, experience necrosis. The way that we do that is by taking something that's tough, that is collagen, on the outside of the cell. Here's my muscle cell. And we link that tough thing on the outside to something tough on the inside, the sarcomere. So we're stabilizing our sarcomeres, making sure that they don't contract the muscle too much, and making sure that the muscle doesn't get stretched too much either. Whenever you hear complex, what you should think is that it's a bunch of proteins, and that's exactly what it is. We also have some carbohydrates added, so we glycosylate dystrophin. That helps it kind of stick to these proteins that bind to the extracellular matrix. But we got, a few moving parts. Some proteins that hook up with the sarcomeres directly. We got other proteins that help link those direct proteins to the cell surface, and then we got the surface proteins to actually hold on to collagen. So it's a chain of proteins, and if anything breaks along the way, this whole thing falls apart. And that's what I'm trying to summarize down here. So in muscular dystrophies, whether it's Duchenne and Becker's muscular dystrophy, where we have problems with dystrophin, or limb girdle muscular dystrophy, right? Problems with Desmond, that's the protein that links us up here, right? Doesn't matter. Any of these muscular dystrophies, we have a problem somewhere in this chain, in this dystrophin complex, so that the tough thing on the outside, the extracellular matrix, is no longer linked to the sarcomeres. And that makes the muscle prone to stretch. If we stretch the muscle too much, we pop the cell membrane. I hope you like the font. I did spend some time picking that one out. I think it's called Party. So when we pop the cell membrane, we experience necrosis, and that, of course, leads to inflammation, as well as weakness. We just killed a muscle cell. But since we did it through necrosis, inflammation is a potential issue. So, indeed, if we have mutations this is Desmond. So this is one of those dystrophin complex proteins that links up to the sarcomere. WT is wild type, so this is control. And then they have homozygous knockouts. homozygous mutants. So they have a mutated form of desmin that we see in muscular dystrophy. So here's my muscular dystrophy, the HOM here. Notice the amount of force that my muscle can generate is cut down by more than half, comparing control to the muscular dystrophy model. Then what they're going to do is pull on the muscle and see when does it fall apart. So when they stretch normal wild-type muscle, it eventually pops. Here they have 5 muscle fibers, and they're just pulling based on the resting length and seeing when does it pop. And with heterozygotes, that means they have 1 mutation. So a mutation in one of the versions. Here we have both versions mutated. And in wild type, we have 0 mutated. As we increase the number of mutant desmins here, that is, as we decrease dystrophin complex function, going from wild type to het to homozygous, notice the triangles, all of them snap at 150% of the length. And about half snap at 150% of the length for the heterozygotes. Okay, so muscles are weaker and easier to break. That's all we're showing here, just providing some data. Now, what it looks like under a microscope is this. So here we can see a few necrotic muscle cells, and I've put an asterisk on them so you can see them. But it should be fairly obvious. So the plasma lemma has ruptured. That's going to trigger necrosis. That is necrosis, and that triggers inflammation. And so what do we see with chronic inflammation is, well, a lot less muscle and a lot more connective tissue. That's this stuff right here. So this is the fibrosis that is typical for muscular dystrophies. And that's because the muscle cells keep breaking. They keep undergoing necrosis, and that triggers an inflammatory response, leading to fibrosis. If this muscle keeps breaking, I need to toughen it up. And so the fibrosis is really just a homeostatic response. This muscle keeps breaking. I need to make it tougher. What that also does is make it stiffer. Okay, so that's one option, dystrophin complex dysfunction. The other option is some change in gene expression. And anytime you change gene expression, you generally decrease the function of that cell. Okay, so here's what we're hopefully going to do. We're going to make the right amount of the right RNA. So here's my RNAs floating around. And then some chaperone proteins. So we're going to turn that RNA into amino acids, and chaperone proteins are going to help fold those amino acids into the correct shape. In this case, of course, green smiley faces. Because green's my favorite color, and green means go. All right, that's what we want. We want the correct amount of the correct proteins. There's a couple problems that might happen in muscular dystrophies. First of all, we might read the wrong parts of the DNA because we're not methylating it like we should. So there can be mutations in methyltransferases, and now, we're making the wrong RNA. We shouldn't express this. As a result, we make the wrong proteins. Oh no. The example here would be a transcription factor that then causes us to make other wrong proteins, amplifying the problem. So could be we're reading the wrong DNA, making the wrong proteins. Okay, maybe we're reading the correct DNA right here. Okay, so here's my RNA that I wanted, right? The good old gene we saw in the last slide. And then I should turn that into green smiley faces, but if I have mutations in chaperone proteins, that's this purple jelly bean here, if that one's gone, now my proteins don't fold up properly. I know I'm not folding RNA. Okay, bear with me. I'm folding the amino acids into the wrong shape. It's green, but it's spiky. That'll kill you. So we make the wrong protein. Damn, that'll lose function. But wait, that's not all. We also see these RNA repeats, these repetitive RNA sequences. And repetitive RNA tends to sometimes fold over and form what looks like double-stranded RNA. Right? See how that folded over? Double-stranded RNA. That's what it's going to look like. And cells use double-stranded RNA to turn off genes. Okay, so now we're making this repetitive RNA that decreases the production of the correct genes. So not only are we maybe not folding it up properly, we're also not making enough of it. So we're either making too much of the wrong thing, or we're not making the right thing from our genes, or we're not making enough of the right thing. Lots of options here, but in the end, if you don't express the correct genes in the correct places, function decreases. And what we need to worry about is that proper balance of pro and anti-apoptotic BCL2 proteins. Remember that death is the default. So I need to continually make those anti-apoptotic BCL2 proteins and not make the pro-apoptotic ones. Hey, guess what? That wrong protein, one of the things that wrong protein seems to do is increase the expression of pro-apoptotic BCL2 proteins, shortening the lifespan of muscles. Okay, lots of options. Either way, we end up with damaged muscle cells. So it's a myopathy. Spinal muscular atrophy is a neuropathy that's caused by the loss of lower motor neurons. That, of course, leads to muscle weakness and muscle wasting. The muscle wasting is not by necrosis, though, so we're not going to see, big kind of hypertrophy-looking muscles. Instead, they'll just waste. Okay, fairly rare, as you can see, 10 to 15 per 100,000 live births per year. The risk factors, there's only one. You have to have mutation in SMN1, survival motor neuron 1 gene. And it's named that because it's a gene that allows motor neurons to survive. How lucky. Obviously, we named it after the problem. Okay, so what's going on over here? There are a few patterns of presentation from mild, intermediate to severe. And what you'll notice, kind of like with muscular dystrophies, the earlier the onset, the more severe the problem and the worse the outcome. So if we see signs of lower motor neuron weakness early on, days to months, we can expect poorer outcomes than if we see it, after 2 years of age. Now, everything progresses and gets worse. So look, even if you're surviving, you're independently ambulating, this will eventually progress to the point where a wheelchair is needed. Unless, of course, we get some nifty gene therapy. That's an option nowadays. Okay, so what's going on here with survival motor neuron 1? This is a protein that seems to be really important for RNA processing. That is, to put it mildly, gene expression. Hey, this is the same thing that we saw in muscular dystrophies. We're going to have a problem expressing our genes. We won't make the right protein in the right place at the right time. What it looks like SMN1 does is help move DNA and RNA around. No, not DNA. Sorry. To move RNA like out of the nucleus into the cytoplasm. Okay, so the red down here is propydium iodide, which stains DNA and RNA. So the red is nucleotide. Okay. Here is a normal lower motor neuron, nothing going on, no mutations that matter. And notice it's red kind of all throughout the cell body, especially when I put my red laser pointer on it. So we made the RNA and we shuttled it out of the nucleus. So the whole cell looks red. Spinal muscular atrophy. Okay, when we have those SMN1 mutations, notice we're not really filling up the cytoplasm with red. So motor neurons use SMN1 as an RNA processing protein, probably helping with maturing the RNA, but also, it seems, moving it out of the nucleus. Okay, so if you don't properly process your RNA and you don't make proteins, you're going to have a hard time surviving because remember, proteins do everything in life, pretty much. So if something happens in a cell, it's probably because a protein did it. Now, that variable expression, where we might have mild, intermediate, or severe, depends on how many copies we have of another gene, SMN2, survival motor neuron 2. It seems to have the same function, but it just doesn't do it as well. Consider this a lazy SMN1. So it does the same thing, but not as well. Now, we have variable copies. And as you have more copies of this lazy protein, you can somewhat make up for the loss of the hard-working SMN1. So you get a spectrum of how much gene expression is affected. If you have a very low copy number of SMN2, you have a big effect on gene expression and thus early presentation. However, if you have If you have many copies of SMN2, then you have more SMN2 protein and you kind of make up for it. So it takes longer for the symptoms to appear. That's the idea anyway. So once the motor neurons die off, then the muscle obviously can't function, use it or lose it, and the muscle wastes. There's pretty nifty treatments for this, so we can actually use gene therapy to reintroduce SMN1, and we can actually prevent the progression, at least in the few studies that are out there now on this. And this is out there in the wild. People are using it. Pretty nifty stuff. All right, so you should be able to answer all these questions. If not, drop me a line in the questions box or come on by the office. I'll see you in class.